the problem they had was that they'd invested a lot of money in this building, right? So the hospitals need to be full, right? With the way the American healthcare system works, the hospital, to survive, needs to be full. So you think about, absolutely, yeah, it needs to be full, right? So think about the conflict that's already there.
Yeah.
This building has to have people in it to continue to run.
Wow.
Now you think the hospital's here to promote the health of the community or whatever the case is, right? But really it needs to have sick people in it to continue to run. So a common experience that we would have in that environment was we would get called to admit people to the hospital that didn't need to be in a hospital.
Welcome back to Dear Healthcare, It's You. Welcome back to the podcast. I'm Joe O'Hanlon, and this is Dr. Elisha Yagmai from the Free State Healthcare Clinic in Wichita, Kansas. Thanks for being here again. And today we're kind of talking about the last part of your medical journey that led you towards starting what we've just mentioned, the Free State Healthcare Clinic. So last we were in Parsons, where you were doing rural medicine at a hospital. You were a hospitalist there. And then you had mentioned in the last episode that it was your wife had a fellowship that she was going toward. Okay, so that brought you to Seattle.
Right.
So tell us about that chapter of your experience.
So Seattle was the complete opposite end of the spectrum from rural health. So the hospital system that I was working in was a multi-hospital system.
Meaning that there are
multiple hospitals
all
related to each other, right? When they shared records and everything else, right?
Opposite of what you were talking about.
Opposite, right? Yes. So they were all together. It was obviously in the heart of a large city. And it had basically every conceivable resource. Like it was almost anything that you could want, almost any specialty, almost any diagnostic tool, almost any lab, whatever it was, they had all of it there.
Were you a hospitalist again?
I was, yes. I was a hospitalist. I did a combination of days and nights at different times, depending on what was going on. Worked in all the different hospitals that they had. Some are more community-facing, some were the kind of tertiary or quaternary referral, meaning they get the referrals from the places that have already tried to work on the case and can't. They've run to the end of what they can do, so then they refer it up the chain. So it was a regional referral center, meaning people were calling in from different states in some cases, right, to send in cases. So
for similar reasons that you were talking about last episode,
yes,
of like
exactly.
just needing more than they had.
They're at my hospital and I don't have whatever it is, or I can't figure this case out and you need to take over, whatever it was.
Gotcha.
Right? These people would be calling in from around the area. So professionally, it was an excellent experience from a professional standpoint, because we got off, those types of centers do cases that are nowhere on the normal pattern in many cases, right? So the patients coming in often are very complicated. They have they have all the traditional problems, they have all of them, right? And then they're having some other problem. And sometimes it's typical cases that you have, but in other cases or in other situations, it's the type of problem where you can't read a textbook to figure out what to do about this, right? There's no protocol for it. There's no guideline for it.
Which was your MO
exactly,
in
right?
school.
Yeah,
it was read everything about.
But there isn't anything, right? So now you're in the realm of what I would describe as expert opinion, meaning we're going to take some physicians that do this and only this.
Yeah.
They're very focused in this one area. They have a lot of experience doing this very narrow thing. We're going to put them all together, and everybody's just kind of stand there and kind of do this type of process and discuss and try some things and sort of see what they can get to navigate the problem. Right. Because the level of complexity is just so high. Right?
Within the hospital's infrastructure, or is this like calling out?
No. Everybody's there. Everybody and everything is clustered within this one place. Right.
Okay.
So it enables you to provide a pretty high level of care to people, and a fairly well coordinated level of care, I would say, as well. And so, having the opportunity to work in that environment professionally was very, very helpful, because I saw a bunch of things that I had not seen before, rare cases that I had not previously been exposed to. Yeah. Just going. So again, going back to that model of sort of feeding in information, right, and trying to burn in patterns, right, where you've just expanded your base to do that.
How many patients were you seeing a day at the time?
It would vary. So during the day, we might have 14 or 15 people that we were seeing, and then we might do some admissions, right? At night, it was often very busy. You might have, 8 or 10 admissions, depending on what was going on. It could be more, depending on the night. Yeah. And you were busy. So like when we were on night call, there were several hundred beds in the hospital. You'd be running around, cross-covering the whole service. So cross-covering means if anything happens to the patient between 7 p.m. and 7 a.m., if any event goes on, the nurses will call you. They won't call the daytime doctor, they'll call the nighttime doctor to handle whatever that is. Yeah. And at the same time, you're being called for any admissions to the hospital, anybody that codes, meaning their heart stops, right? You're responding to that. Anybody that's starting to get sicker, you respond to that. When I first got there, the ICUs were still open at that point. So if it was an ICU patient, you'd be there. You were just kind of going all over the place. Okay. and doing that kind of work. So, from that element, it was fantastic. And they had they had a heart and stroke specialty hospital and all these other types of things, right? So you'd go work there, and it'd be just all these patients were all heart patients and very, very sick and with specific pathology, and you'd just be going down these different areas. And while I was doing that, I maintained a second job working at an urgent care in the area because I wanted to maintain a touch with ambulatory or outpatient medicine.
Oh, okay.
So I worked that job. So I did my hospital shifts, and then I had my urgent care shifts. I did both at the same time. And then I'd periodically I'd go down and work. So they had a pediatric emergency room. I'd go down there and work from time to time. That was like a moonlighting gig on top of the other stuff. And then I'd periodically come back to Kansas, periodically to round on the inpatient pediatric service here in Wichita. Yeah.
Oh, okay.
So I would do all of those things.
Why would they, that's unique. Why would they do that? Why would they have you come from Seattle?
At the time, obviously I'd graduated from the program, so they knew me. And then at the time, they had a need. They had a need to fill the staffing at the time. They didn't have...
similar to what we were talking about last episode.
Exactly,
just filling a need for someone's off for a week,
Correct,
so you're covering.
Yeah, that's exactly right. They didn't have enough staff to cover every single shift, right? So when they had open shifts, and I periodically would fly back in and cover some shifts for a week or something like that, and go home.
Were you sane during the time? I mean, that's so much work.
I mean, yeah, it was
like coming off of the rural place. It sounds like that was a little bit of a difference. Where you were 5 days a week, so it was a lot for 12 hours and stuff.
I'd be doing 7. No, I'd be doing the 7s in the rural place. Right? So I'd be on checking all the patients, doing that. But then every 2 weeks, I'd have a weekend off. That's how I did it.
Okay.
Right? In this place, I was working frequently, very, very frequently. Was it sane? I mean, on some level, probably it wasn't. But
I'm just thinking of human standards.
Yeah. I didn't feel that way.
Yeah.
But I think it's also because of the stage I was, right?
Right.
I had recently come out of training.
Mm-hmm.
This is the first time all the training wheels are off, right? No one is looking over your shoulder anymore.
Yeah.
You don't have any kind of a safety net.
Yeah.
You're in charge, and the buck stops with you.
Right.
And
which you did have in the rural setting too.
I did, but that was for some months,
very different,
before we left.
Yeah.
No, it was similar. It was an extension of that, but it was. But it's just, I would say that there's a big learning curve when you come out of medical school and go into residency.
Yeah.
And then there's another huge learning curve when you go from residency into being the attending physician, because now you make the decision, and there's nobody else that has any more accountability than you do, for what's going on. So that again. And
accountability or liability.
Right, both of those, right? And so you come out, the other piece I would say is that training environments tend to get a little bit circumscribed, meaning there are certain types of patients, certain types of problems that are very frequent in training.
Yeah.
There's a whole nother world of medicine that frequently takes place outside of the training environment that you don't get exposed to in training unless you do some moonlighting like I described. Right. You don't get to see it. This was the full world, right? Yeah. Now you're getting everything from everywhere all the time. It's all coming in.
Big city hub playground almost for learning.
Yeah, that's correct.
Yeah.
So that was the professional environment in which I was operating.
Yeah.
And so for a while that was kind of all consuming, and and I think, and I don't regret it. I don't have any regrets about doing that at all. I learned an enormous amount.
For sure.
And both from the work and then also from the people that I was working with, right?
Yeah.
Because these were people that have been practicing for a number of years, right? So I'm working with them and learning from what they do, and handing off patients, and all these things were going on. So it was great from that side. I think that the flip side of it was also seeing kind of I would say describe it as the downside of some of these places, which is from a medical perspective. There were times when we couldn't turn it off, would be the way I would describe it.
What do you mean?
So for example, I had one patient that came in. At the time, that patient had esophageal cancer, which had ruptured, so it popped a hole in his esophagus, and he'd had basically secretions from his intestinal tract go into his lung.
Oh, wow.
He also had recently had lung cancer. That was, I think at that point, it was in treatment, if I recall correctly. Right, so he at that time he was requiring 3 different medications just to keep his blood pressure at the bottom end of normal.
Okay.
He was on a ventilator, so on a breathing machine, right?
Wow.
He had an active cancer, which had just popped his esophagus open, right? And then had another different cancer also going on. So I think, you look at that type of situation, right? And this was an older gentleman, right? You look at that situation and say, maybe we should stop here.
Yeah.
And the reason you say that is because cancer that advanced is probably not going to go well.
Right.
There's going to be a lot of medical complications. There's going to be a lot of just harm even from the therapy given. Right. And so maybe this is a situation where we should consider a different course. Right.
Yeah.
And so I tried to sit down. Oh, sorry, go ahead.
You're talking like quality of life too, in terms of, in the meantime.
There's a whole discussion you can have, right? About quality versus quantity and what matters more to you, right? But it was the type of situation that in a smaller environment, probably everybody would have stopped, in part because there were no resources to go further. Right. But in this environment, every resource was available. So I tried at the beginning to sit down to the family and say, this is a terminal situation. Yeah. He is not going to live. No matter what we do, he will die. Right? Yeah. So it's only a question of when, right? Yeah. Does he die now? And do we take all these meds away? And what will happen is he's going to go to sleep. It's probably not going to be painful to our knowledge. He's going to go to sleep and he's not going to wake up. Yeah. Right? That's what's going to happen. Versus we're going to keep all these things going. We're going to keep the tube in his throat. We're going to keep poking him for labs. We're going to keep all these meds. I don't even know when he'll get off of any of these or if he ever will, for that matter, right? And then we keep trying to do, diagnostic workup and all these other kinds of things. So, I met with the family, I expressed that to them, and their only question was, well, what does the surgeon say? He had a surgeon involved in his care, right? What does the surgeon say? So the surgeon comes in and is like, well, there's this, narrowing in his lung, on the CAT scan, and, we need to find out if that's a recurrence of the lung cancer, if it's something else, right? And I'm saying, well, I'm not sure this matters, right? I'm not sure it matters at all what this is. And, they, of course, they went with the hopeful message, which is we're going to find some things and we're going to do some tests and, we're going to get through this. And so, the end of that case was he spent 3 weeks in the ICU. He never came off the ventilator. Yeah. They did a bronchoscopy 3 different times on him to try to biopsy the narrowing in his lung. They may have gotten something diagnostic on the 3rd try, if I recall correctly, right? I mean, I'm sorry, it wasn't 3 weeks, it was 2 weeks. Well, they have to go down your throat, they have to sedate you and go down your throat. Now, he was probably on sedation because he was, on the ventilator. But I mean, they and I wasn't involved in this care the entire time, right? Yeah. I went off the case, but I followed along, and he, in the end, he died, right? After 2 weeks in the ICU and multiple invasive procedures and all this other stuff, they withdrew care and he died. Yeah. Which is what we could have done 2 weeks before. Right. But we because we have all these tools, right? All these tools and all these resources, the default mode was do, right? Right. You got to do something. You got to do something. You got to do something. And I would say this is generally true of medicine at that level, right? The question is not, should we do this? The question is, can we do this? Right. And the problem is that medically, ethically, humanly, the most important question is almost always, should we do this? Right. Right. Those questions were frequent, and there are many, many, many other examples, right, in that environment where what we were doing from one perspective was kind of insane. Yeah. And I've since talked to docs that have worked in other large centers, and many of them have shared similar experiences, right? Where it's just not clear what we were hoping to achieve with this, right? And then I'll go to the opposite direction. So I had another patient. This was a very elderly man who's thoroughly demented, so he had just no idea what was going on, right? Yeah. And his power of attorney was his daughter, right? And so what would happen is he would decompensate every so often.
What does that mean?
Decompensate means he would just get very ill. He'd get acutely ill for whatever complication. Because what he would do is go home and lie in a bed. Right? This is what would happen. Right? So every so often, lying in a bed is bad for you, right? Right. Your mind is not clear, right? So you could swallow something the wrong way, you get a bed sore, you get an infection, whatever, right? Mm-hmm. So she would bring him in every couple of weeks with these events, and we would go through all the process of reviving him again and again and again and again and again, right? It was very, every time you have to poke him for labs and do all these other types of things, right? And it was very clear, even though he was demented, he would try to fight off this stuff, right? Anything we would do to him that was painful, he would fight off. It was just really obvious from looking at him, like, this is just miserable. Like, it's just miserable. He doesn't get anything out of it. Right. He doesn't know what's going on. All he knows is in this place, it's not the normal place, right? And these people just keep torturing him. Right. Right. This is what's going on. And so here again, I tried to talk to the daughter, and she said, well, I bring him in here because, it'd be so hard for me if he died. I would just really have a hard time with that. Right.
Which you laugh, but as from the family side of things, right? No, is a reality.
No, I get it. I got it.
But
right?
Yes, but
at the same time,
you're seeing this patient suffering.
This person is suffering, right? Yeah, you wouldn't do this to your pet,
right?
you wouldn't do this.
Well, some people might.
Well, maybe they would, right? But
but that's, yeah.
So, when I think the difficulty with that, right, was that I'm standing there with a straight face saying, okay, you understand. And this is the thing.
Yeah.
These are actually the other piece of the, so she said, I know that he hates it when I bring him here. I know he hates it.
Yeah.
I know that he doesn't like it. But I couldn't stand to have him die.
Right.
Right. And you know what I mean? And there's some kind of an ethical conflict in there, right? That needs to be hashed out. But it's not hashed out, right? The answer is the person with the authority says, do it. So we do it.
Right.
And we do it again and again and again and again and again until sometime when that same gentleman finally crashes so badly that we can no longer keep his body moving forward, right? And then he will die.
Right.
Right. By force. He will die by force, right?
Right.
This is the reality. And so I think, again, you have to ask in those situations, is that how this should go?
Right.
I'm not even saying, I think it's obvious what my opinion is,
but it almost is like, hearing you say that, I'm like, I think that it could be beneficial for some of the bedside manner to include that honest conversation at those earlier times, which it often doesn't.
It often does not. Yeah.
Because, sometimes maybe the family needs an authority to let them know that there is another option. I mean, that's what happens at the vet. When when you take your pet and it's like they are too sick and you get advised to put them down or things like that. It's like that becomes part of the conversation. And not that we're putting people down, but I think that there comes that point in conversation that is missed a lot in any sort of medical setting, not every time, but a lot of doctors, bedside men. I've been in the room with many people who have died in the hospital, and or a few, not many, but and it's like to get the doctor that tells you like it would be beneficial if you tell them that it's okay to go, like, or those releasing things. It's like that makes a huge difference to be able to have that conversation. Do you feel like you were allowed to have that conversation, or was it not able to, like, because you were working with so many other doctors, it was not always your call?
That's precisely the issue, right? So I would try to have that conversation at any time I felt it was necessary.
That way, yeah.
The difficulty a lot of times is that it depends very much on the psychology of the person, right?
Yeah.
Some people want to cling to what they perceive to be any hope.
Right.
So if you say, I think this is really the right time to stop.
Right.
But some other person comes in and says, oh no, we have this whole list of toys and tools that we could use to do blah, 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 right?
Right.
And they present that as being super hopeful. What may actually be going on?
Hopeful and helpful,
right?
Yeah,
and they may be missing the forest for the trees, right? The issue, and this happens in many cases where the person that's coming in only sees the tree. Right. They see their one little area and say, well, I could do some more work in here, right?
Yeah.
Without understanding that the entire forest is actually on fire.
Yeah.
Right? But the problem is that the family, again, the family, whoever it is, right, doesn't have any way to assess this really.
Yeah.
So they go with who's offering me the most hopeful sounding message.
Right.
Even if it's not at all reflective of reality.
Right. Because it feels like there's an obligation to do that.
Yes.
To your loved ones. I mean, and that's, that's a really difficult point of medicine, I feel like, in the bedside manner category of things. But I guess it complicates things more to have more ability to do more, because then it makes that question a lot more open-ended of like, when do we start to have this conversation?
Yes.
Yeah.
And that's in those settings, to some degree, it's almost you die by permission. That's not 100% true, but to some degree it's true, because at this point, medical science we can flog bodies along for a long, long time.
Yeah.
But we cannot necessarily give you back your quality of life.
Right.
Right.
Which is a really important distinction.
There is, but the two are often confused, right?
Yeah.
And doubly so when you're walking in that environment, you don't know anything about medicine.
Right.
All you've heard is all the marketing from this place about how much hope and care they provide, right? And so what you're expecting may be very different than what can be done.
Right.
But the two look like the same from your perspective.
Which is not even to speak to the amount of debt that could be accumulating in the meantime that'll be left for those that are left behind.
Massive amounts in many cases.
Yeah.
So added to that, the other thing that became apparent over time was that a lot of modern hospital care and modern medical care in general in the United States operates in what I would describe as the medical industrial complex.
Okay.
What I mean by that is we talked a little while ago about sort of this concept of just cranking volume.
Yeah.
Meaning you're just moving people through. You're
Right.
just moving people through. Not necessarily mindfully, right?
Right.
Just cranking them through,
Factory
next thing.
mentality, like-
And we saw enormous amounts of that, right? So
even with it being a referral center.
oh yeah. Because so for example, there was a new branch of that hospital system that was started in one of the smaller outlying communities, right?
Okay.
So we would go there to work, and the problem they had was that they'd invested a lot of money in this building, right? So the hospitals need to be full, right? With the way the American healthcare system works, the hospital to survive needs to be full. So you think about, absolutely, yeah, it needs to be full, right? So think about the conflict that's already there.
Yeah.
This building has to have people in it to continue to run.
Wow.
Now you think the hospital's here to promote the health of the community or whatever the case is, right? But really it needs to have sick people in it to continue to run. So a common experience that we would have in that environment was we would get called to admit people to the hospital that didn't need to be in a hospital.
To that branch that you're speaking to?
Yeah, so we'd go out to that one to work, right?
Oh, okay.
It was very well known, right?
Yeah.
So we would get called and they would say, and I'll give you a good example. So I had one, what they described to me were, they told me the patient, I think, had some kind of tumor or something along these lines, right?
Yeah.
I go in and talk to the patient. Turns out the tumor is very well known. It's not malignant.
Okay.
And it wasn't the problem. It wasn't the problem at all, right? So what was presented to me as the reason for admission was not the reason for admission. I called the patient's doctor to confirm all of this. It was all true.
Yeah.
I then got the patient's actual story, ordered a couple of lab tests, diagnosed her, and discharged her. This all took 30 minutes.
Yeah.
So in other words,
she was about to be admitted.
No, she was admitted.
Oh, she was
because
admitted
I was given
already.
an incorrect story for why she was being admitted, right? So I admitted her, and 30-ish minutes later, I discharged her from the hospital, having correctly diagnosed her. I found the problem that she actually had, which was obvious if anyone had talked to her.
Right.
Ordered the necessary tests, validated the diagnosis, sent the patient out the door with meds and follow-up.
Yeah.
So I did a $2,000 or $3,000, primary care visit.
Wow.
Right, done there. I had another one where they called and said the patient was vomiting, right? It had to be put in because they were vomiting. I go in and talk to the patient and said, okay, so I was told that you were vomiting. Yeah, that was 2 days ago.
So
and I said,
still vomiting,
well, I'm sorry,
apparently.
you last vomited 2 days ago. Then why are you here? Oh, because I called my doctor and they said, well, if you were vomiting, you should go to the ER and get some labs checked to make sure everything is okay. And then they told me that I needed to be in the hospital, right? And I looked at this and said, well, ma'am, your labs they're actually all right. They're all right. They told me that you were vomiting today. No, I wasn't vomiting today. Right. So here again, I called the patient's doctor to validate the story because I was like, this is ridiculous, right? This can't be true. Patient's doctor completely validated the story. Yeah. Discharged the patient. Right. I had another one. They called me and said the patient's unresponsive, needs to be admitted to the hospital. Right.
Okay.
They roll the patient upstairs. I walk into the room. The guy is sitting up in bed, looking at me, and says, "Doc, why am I up here?" And I said, well, sir, I was told you were completely unresponsive. He was like, I told that guy downstairs I didn't need to be in this hospital, right?
Wow.
And the case after, there would be cases where we would be called to, we would be called to do an admission. They would have done no intervention. Like they hadn't tried any therapy on the person. Yeah. They had done no workup. There was no lab
Because you can be
work
treated in a hospital without being admitted.
You can be treated in the emergency room, right?
Yeah.
You can be treated in the emergency room and sent home, right? But instead what would happen was the person would come in with something that you could at least hypothetically turn into an admission. Right. Now the reality was they wanted to be treated and sent home. That's why they came. Right. But, a doctor has come into the room and said, oh no, this is really serious. You need to be upstairs, right? So of course, they're not going to question that. Right. So they would just admit them to the hospital, right? And then the problem is that we would get the call and we would look and say, the patient has been in the department for 15 minutes. You have not ordered any of the appropriate medications to intervene in this condition to see if they could go home. You have not done any workup on them. Yeah. How do you know that they need to be in the hospital, right? Yeah. These kinds of things went on all the time. And
At what point was it very clear from the beginning that it was about money?
No, when I first started, it wasn't immediately clear.
Was it confusing?
It was. Initially it was, but it became more and more apparent. Right? Yeah. And so in the scenario that I'm talking about, eventually we got feedback that came down the chain that said, y'all need to stop obstructing the emergency room. right?
Oh.
You need to stop obstructing the emergency room. And our perspective was, we're not obstructing the emergency room. When they call us with something that genuinely needs to be in the hospital, we take it every time.
Right.
But when they call us with a patient that barely needs a doctor, much less needs to be in a hospital,
yeah,
we...
what
do you want us to do, right? No, I mean,
Right.
it's what do you want us to do, because this is an expense, right? And this is what I'm talking about, right? So we're sitting here thinking, this person's going to get charged thousands of dollars for this, that didn't need a hospital,
right?
So we're not.
So you're thinking on behalf of the patients still,
Absolutely,
like on their side of things,
yes.
like rather than the hospital's thinking we need beds.
The hospital's thinking we need people in beds, right? So the
we
ER
need to charge them for having been in a bed, whether they stay in it or not.
Exactly, the ER is funneling folks through, right?
Yeah.
But we're saying, and the ER, there's reasons why the ER does what it does, which we can touch on later. But from the patient's perspective, right? I didn't go to the hospital to be admitted. I went to the hospital to have someone assess me, treat me, and hopefully send me home. Right.
Yeah.
But instead, we're putting you in the hospital, which means you're getting a charge for hospital admission that you did not need.
Right.
I had
usually multiple extra charges, right?
Exactly. Well, you're getting charged by everybody, right? The physician group that saw you, the hospital facility fee, right? Any other testing you may have had done. Any of this stuff could be in there, right? But I had multiple admissions where I would admit the patient and discharge them within an hour, right? And that clearly was a patient that did not need to be in the hospital.
So it was a doctor's visit.
And it wasn't like they rolled back, they bounced back later because they got sick. No, they went home because they never needed to be admitted in the first place, right?
Right.
But again, when you would do this, what you felt was the appropriate decision medically, what you got from the higher levels was you need to stop blocking our ER from putting people in the hospital, right? So this was, that was a reality of practice, right? And so there were lots of other things that went on in that context that made it apparent that the goal here ultimately is money, right?
Yeah.
It's the generation of money. Now, you can say, well, they're greedy, and my hospital's not. No, they all work like this. Right. At this point, I've worked in dozens of hospitals. Yeah. They work like this because they have to. Right. Right. So
because they're a business.
They're a business, but it's not just that they're a business in a thing that maybe should be a service in a different way. Right. Right. You could conceive of how it could be different, right? Right. The issue that we get into, I think that the problem that we have is if I have a building that I must keep full of people, right, to remain solvent. Yeah. My incentive is to keep that building full of people. Right. Whether they need it or not is a different question, right? Yeah. And it's not even necessarily nefarious, right? In other words, I don't have any incentive to, for example, build an alternative structure to myself. Right. I don't have a strong incentive to necessarily build up the primary care structure around. Mm-hmm. I don't have a strong incentive to help people get treatment outside of a hospital setting. Right. I may be, in other words, my building may be the most expensive and difficult place for you to get care, but I have no incentive to seek or even contemplate an alternative, right? Yeah. Because in doing any of that undercuts my finances, which undercuts my ability to survive, right? So here on a system level, you could say, well, do we need hospitals? Do they serve some useful function in the community? I would say, yeah, they do, right? They do serve a useful function. When you're operating them in a system like this, though, you are causing their needs directly contradict the needs of the community. Right. Right, because the community needs healthcare that it can access and afford. Right. But the hospital's sort of main function is I need to get volume in here and I need to charge as much as I possibly can for everything that I do. And they will say, well, it's because I take care of all these uninsured people and other people don't have. But there's no reason that has to be the system. Like that, there's no reason that has to be the system. They act like that's the default system and there's no other possible way you could do this healthcare thing. Yeah. None of that is true. Right. So you've completely cut off any attempt at creative or alternative thought in terms of how to address these health problems because there is no incentive at all for any of these institutions to do this on a general basis, right?
Well, it comes back to that question that I don't know if we've said it on screen or not, but about asking, like as a hospital or this infrastructure of hospitals asking themselves, do we need to exist? Yes. The same way. Like, that's a challenging question to the very nature of hospitals, but is an important one to ask. Yes. Yeah. Seems like you found that question there, or was that before already kind of like in your mind, having been in other hospitals?
It was percolating a little bit, but that it began to crystallize in that environment, right? Because it was, I mean, I think all these stories that we've been through, right? they all have a system-related cause.
Yeah.
They're not as simplistic as just a bad actor,
Right.
bad day.
Yeah.
Those people are super greedy.
Right.
These people are shady. Like that's too. Well, number one, at this point, having worked all the places I've worked, I've seen the same behavior a dozen different times in a dozen different places, right?
Right.
So it's not just that's one bad person, one bad apple.
I was
right?
just going to
Let's
say,
get
it's
them
like
out.
the defund the police conversation where it's like, at what point do we stop saying, well, there's always bad apples,
Right.
and start saying, well, like,
Yes.
who is supposed to be picking the bad apples out?
Well, it's not just that they're bad apples, right? People respond to
yeah.
incentives to some degree.
Right.
You've built an incentive structure
right.
that pushes people into a certain type of behavior is the favorable behavior to achieve the incentive, right? So if you want different behavior, you need to ask, what incentives have I put forward?
Right.
And are those the ones I want?
Yeah.
Right? And is this thing doing in my structure, in my system, in my community, is it doing what I want it to do?
Yeah.
Or is it doing something different than that? And if it's different than that, what do we do?
Right. Because it's like almost the access to affordable health. I'll just say access to healthcare is like pennant on it being unaffordable.
Yes. Right. The idea, right? So the fact that I charge $75,000 for a hip replacement enables me to care for the next two people that come in the door that don't have any money.
Yeah.
Right. Why do we have a
when
system
your insurance company already charges you this for the money that they don't use for the other people?
Right. It's
like happening at multiple levels for everybody to get their buck.
And as you escalate your price, right, your service becomes less and less and less and less accessible to anyone in your community, right? So then the average person's like, I don't want to go there ever, right? Because I can't. They'll bankrupt me.
Yeah.
Right. So
because if you go in for stitches, and you're going to get admitted because it's happened before or whatever, it's like that you can't afford it. Yeah.
So you're going to have bills for the next 2 years out of your 1 ER visit.
Right. Well, we're out of time, but next time we'll be talking about how all of this led to Free State, because I'm really interested. I still don't know all the ins and outs of Free State too, so I think that'll be a good opportunity to just hear more from you about Free State and about why it's structured the way that it is and how you kind of found these ideas or came up with the ideas and then got the people, place, and all the things in place to actually get it off the ground and going.